Yeah, very good morning to all the speakers and the panelists and the audience who have joined today for our webinar on perspectives in thoracic transplantation and MCS during COVID pandemic. And first of all, I would like to thank Prakash, who has taken a big role in getting our Australian speakers to this webinar meeting. Thank you, Prakash, on behalf of all of us. And the flow is like this. After this, the Prakash and Dr. Ravi would introduce the speakers. And once they finish their presentation, I would invite our invited faculty from our country as well as abroad to speak for a few minutes. And after that, we will open the podium to questions and answers to the audience. I request audience to look at the bottom of the screen. There is a Q&A. In that, please type the question, and Dr. Ravi and Prakash would pose those questions to the speakers. And once that is over, and if there are no other comments, we'll close the session. So with this brief introduction, I request Dr. Prakash to introduce our three Australian speakers who have enormous experience and who have guided us. In fact, I met Peter somewhere in, I think, somewhere in 92. It's a decades of experience behind him and Professor Allen. Go ahead, Prakash.
Dr. Gokhale, I have a small question. The invited commentary, we would ask Dr. Sandeep, Dr. Bala.
Yeah. What I'm going to do is, after the presentation by the speakers, I would invite these people to give their comments. And after that, we'll open this to question and answers. Then you and Prakash can take it forward.
All right.
Thank you. Prakash, take over.
First, I would like to thank Dr. Gokhale and Dr. Ravi Kumar for permitting me to organize today's webinar. It gives me an immense pleasure to introduce today our eminent speakers. I was fortunate to get trained and work in close association with my mentors. First, I would introduce Professor Peter McDonnell, who is a medical director of heart and lung transplant at St. Vincent's Hospital, Sydney. He's the head of Transplantation Research Laboratory at Victor Chang Cardiac Research Institute, Sydney. In addition, he is a professor of medicine at the University of New South Wales. His major interest over the last 30 years has been in areas of heart failure, pulmonary hypertension, heart transplantation, donor management, and organ preservation. His arduous research into the recovery and transplantation of hearts from DCD donors earned him a worldwide recognition and was awarded for his healthcare leadership and innovation by Australian government. Our second speaker, Professor Alan Glanville, has been instrumental in developing the lung transplant unit at St. Vincent's Hospital since 1989. And he has served as a director of the Department of Thoracic Medicine and the Thoracic Transplantation at St. Vincent's from 1998 till 2019. He has been a past president of International Society of Heart and Lung Transplant. He has authored, apart from 230 publications under his name, various INSHLT consensus guidelines for lung transplant, chronic lung allograft rejections, and so on. Our third speaker, Professor Kumud Detalle. He is a highly eminent and respected cardiothoracic transplant surgeon and a scientist in Sydney, Australia. We know him that he has performed the world's first heart transplant with a distinctly procured DCD heart and was awarded for the same by the government of Australia. And to all because of his specific interest in pulmonary hypertension and related surgery, he is one of the 3 surgeons in Australia who does the pulmonary endarterectomies. Now, Dr. Ravi Kumar I would ask him to introduce Dr. Sarvesh.
So, fourth speaker is Dr. Sarvesh Pal Singh. He is Associate Professor of Intensive Care and Cardiothoracic Vascular Surgery at the Cardiothoracic Center in All India Institute of Medical Sciences, which is Apex Institute in India. So he represents AIMS, India. He's got a fellowship from the Indian Association of Cardiovascular Anesthetists and also has a international traveling fellowship at the University of Leipzig. He has a lot of experience specifically to heart transplant and is one of the few cardiac anesthetists in India with a lot of experience in cardiac heart transplant as well as storage and transport of donor organs, in which he has special interest. And also his ongoing work is now on the survey of the practices of storage and transport of donor hearts in India and 1-year outcome of orthotopic heart transplant in tertiary heart centers. He has 75 research articles to his credit. And welcome, Dr. Sarvesh Pal. for your talk.
Professor Peter, please go ahead.
Yes. Okay. I'm just going to share my screen and just let me know. Can everyone see this? Yes. Okay. So my brief was to talk about heart transplantation in the time of COVID. And I just thought I'd start with a general slide, which you've probably seen this in a number of reviews, but COVID-19 seems to be a three-stage infection, with stage one being the prodrome or a mild constitutional symptoms. And it's probably worth remembering that probably 80 to 90% of people who are infected with the virus really experience this stage and don't progress any further. And a lot of young, otherwise fit people fall into that category. Stage two, which tends to appear between about day 5 and 7 and lasts for also about... Okay, so I was just describing stage 2, which has also been known as the pulmonary phase, which corresponds with the viral pneumonia. And that's really been the trigger for most people being admitted to hospital with this condition. And that's estimated to affect 10 to 20% of infected patients. And then there is this so-called stage 3 or hyperinflammatory stage or cytokine storm stage, which affects estimated between 5 and 10% of patients. And somewhat paradoxically, that can emerge as they seem to be recovering from the pulmonary phase. And a lot of the patients presenting with a predominantly cardiac presentation, such as a fulminant myocarditis or even sudden cardiac death, are likely to fall into this group. You'll also notice at the bottom of the slide some of the potential therapies which have been proposed at different phases of the illness, depending on when the patient presents. And I guess particularly relevant to a transplant population, if you look at the very bottom line, where there's been a suggestion that maybe we should reduce immunosuppression in patients presenting in stage 1 or 2, but paradoxically, the patients who are stage 3, we're starting to consider, high-dose pulse corticosteroids and other immunomodulatory agents as shown there. So the approach to this in a transplant population is likely to vary according to when the patients present. I had a look last night at the World Health Organization's global impact of COVID-19, and this is as of 23rd of April. And based on their recording, there's over 2.5 million cases worldwide, with over 172,000 deaths, or 6.7%. And if you look at the distribution, we all know this started in China. People sort of debate as to exactly when it started in China. But this looks at mortality, and you can see the darker the image, the higher the mortality. And when you look at China now, it actually looks like it's been relatively spared on a population basis. And you can see the brunt of this really now is in Western Europe and the US, and to some extent in the Middle East. India and Australia have actually fared reasonably well up till this point in time, at least based on this graph. This shows you the current sort of numbers that for Australia as of the 22nd of April, so 2 days ago. So we've had 6,600 cases with only 74 deaths, and that's a mortality of only 1%. And we think part of that is due to a very intensive screening program where we've picked up a lot of early and asymptomatic patients who are going to get better anyway. In India, this is from your government website yesterday or 2 days ago, and according to that, there were 16,500 odd patients with 681 deaths, which is 4% mortality. Still compares favourably with the If you look at Australia as of the 22nd of April, we only had 162 patients in hospital and only 47 in intensive care units, and of those only 32, I think, were on a ventilator. Now, we, with our public health input, we've sort of prepared for a possibility of needing 3,000 ventilated beds across the country. So at the moment, we're only using 1% of those proposed beds. This next curve or graph shows you the incidence of COVID infections according to age group and gender in the top bar. And you can see that this is mainly a disease of adulthood. Children and teenagers seem to be relatively spared, but it's a very high prevalence in the 20 to 30-year-olds and all the way through to the 80s. When you look on the bottom graph, which is the mortality, and this is Australian data, but I think it's very reflective of what's being reported overseas, you can see that the mortality is very much concentrated in the older populations and seems to be have a higher mortality in men compared to women. Now, this shows you the number of cases reported daily in Australia, and I've truncated the curve here. You can see the first reported cases here in our country were on the 24th of February. And by this stage, the COVID was creating havoc in Italy and Iran and South Korea, and we knew it was coming. And as you can see, over the next 3 weeks, we started to see increased numbers of cases in Australia. And I've stopped this at the 17th of March, where we're approaching 100 cases a day. And it was at that time that our Transplant Society Council met, and we had an annual scientific meeting that was scheduled on the 20th to the 24th of March. And that, like many other scientific meetings, was cancelled because of COVID-19. And what they did in the same session was to establish what has been described as a COVID-19 National Transplantation Donation Rapid Response Task Force. And this was set up in collaboration with our National Organ and Tissue Authority, who are the main body governing deceased organ donation in the country. It included infectious disease experts and epidemiologists. And this task force meets weekly via a Zoom meeting. And its first communique, which was issued on the 18th of March after it first met, was basically to suspend all live kidney donation. It said they had planned to continue with deceased kidney donation on a case-by-case basis. With liver, lung and heart transplantation, again, it was on a case-by-case basis, but the plan was to continue with those life-saving transplants. And it was recommended that all donors and recipients should be screened for COVID if there were referrals. And interestingly, the communique noted at that time that the Toronto lung transplant program was going to be closing for a couple of weeks. I included that in the communique, and Alan may talk more about that in his talk. A week later, you can see that cases now are up to approaching 300 cases per day in Australia. And we thought that we were about to follow on the same course as Italy and Spain, which were, having horrendous numbers of cases and admissions to hospital. So at that stage, as I say, this task force was meeting weekly. We were expecting that ICUs would start to fill up with COVID positive patients, and this would obviously impact on the ability to, not only to support donors who might be in those potential donors in the intensive care units, but also there's a risk of donor infection, and that was obviously an issue to be considered. So they decided, or their recommendation was that all organ offers and allocation should be restricted to local programs. There shouldn't be interstate transfer of organs, and that the Donate Life agencies who act as the donor coordinators should sort of undertake what they described as an early call with local transplant programs to see whether they had potential recipients before undergoing any extensive donor workup. And again, it was recommended that we should be trying to get swabs and ideally rapid results for COVID-19 testing on both donors and recipients. But at that time, there weren't any rapid testing available, although that's now changed. In terms of transplantation, there was obviously the concern that with recipients, there was going to be an increasing prevalence of COVID-19 in community and in the hospital, and that obviously posed a risk of infection to both donors and recipients. There would be increasing the recipient requirements for ICU. The concern was that you may not have an ICU bed to take your heart transplant back to if it was already, if your ICU was full of COVID-19 patients. And obviously recipients, particularly in the early post-transplant period when they're highly immunosuppressed, there was a concern of increased morbidity associated with COVID-19. So they then said, well, maybe we should just restrict transplantation for anyone who we thought was probably going to die in the next 4 months, with the issue being that we thought that by 4 months we would be through the worst of this and then things would be starting to open up again. So at that communique, they basically suspended all kidney transplantation, both living and deceased, or kidney and pancreas. With liver, lung and hearts, they said we should only be doing urgent cases, and that this would be subjected to weekly review. A week on, this is the 1st of April, you can see now for the first time a fall in the number of cases. There was a peak, and then people were starting to think, well, maybe we've seen the worst of this. And so there was some optimism here. So there was expression from representatives of the cardiothoracic group on this committee that we really needed to keep heart transplantation going. We didn't want to suspend it. But again, there was this recommendation about giving an early heads up or early communication between donors and transplant programs before undergoing extensive donor workup. And the committee backtracked on the issue of interstate offers and allocations and thought, well, if there is a suitable interstate donor and the only recipient is another state, then that should go ahead if it's feasible. But this was in an era when commercial airlines were reducing activity, so there were a lot of logistic issues that may be an impediment. This shows you the actual donors by jurisdiction of, between the 1st of January up until April of this year. And you can see this is the States and this is Australia. And as you can see, in the first 3 months of the year, there are about 40 deceased organ donation. But you can see in April, there's been this dramatic reduction in the number of donor referrals across all states. So it's only 11 to date in April. Now, I know we're not through the end of April, but we're coming closer, but it's pretty clear that there's been a reduction in donation referrals. And you can see, compared to the same year to date in 2019, so far there's been a 20% reduction in deceased organ donor referrals. And we think this is going to continue on for the next few months at least. If you look at the impact that's had on transplantation numbers, the biggest impact, as you'd expect, has been on kidney transplantation. You can see about 60 kidney transplants per month until March, and then nothing in April with the cessation of activity. Quite a big reduction in liver transplant activity as well. You can see from the mid-20s down to 9. Big impact on lungs and on hearts as well. Interestingly, if you look at across the on the far right column compared to 2019, you can see for all organs with the exception of the heart, there's actually been a reduction in transplant activity, and we think as in the next month the hearts will be coming down as well. Our own unit has actually had a very busy start for us for this year. We've done 19 heart transplants for the year to date, including 2 in the last week, 2 this week, and they were both DCD donors. One of them was a referral from interstate. So we sent a retrieval team interstate, flew them interstate, and they returned. And we've had one from another hospital in Sydney, and both those recipients are doing very well. This next slide shows you what's happened since the 1st of April, and you can see that there's been quite a dramatic decline in the number of cases, and they're continuing to decline on a sort of almost a day-by-day basis. So we think at the moment, with all the public health measures, particularly social distancing, getting people to stay at home, it really has had a very major impact on the number of cases. And so far, we've really dodged a bullet, so to speak, and we're hoping that this will continue to be the trend, and hopefully even elimination of this virus in the country. The last meeting of the group was on Tuesday, and at the moment, deceased kidney transplantation remains suspended. But given the trend, the trends in new cases, they're expecting that they'll restart kidney transplantation probably in May. This shows you the number of COVID cases, which I mentioned in my introductory slide, both in Australia and New Zealand, and the number of transplant recipients who have tested positive for COVID. And in Australia, there's only 6 at the moment, and none of those have died. And there's certainly been, as far as I'm aware, there have not been any reports of COVID-19 transmission from donor to recipient, but I know this is something that changes on a day-to-day basis. This next slide was provided to me by Jeremy Chapman, and it's a couple of days older than when I just showed you, but this just shows you various countries, and these are transplant recipients. These are all transplant kidneys, livers, lungs, hearts, so it's not just the one. But you can see the numbers of COVID positive transplant recipients, those that are alive in ICU, and those that have deceased. And you can see 120 in COVID positive transplant recipients or have developed COVID, and 23 of those have died, which is, it should be, I think, twice as likely to die, 2 to 3 times as likely to die compared to a non-immunosuppressed COVID-infected patient. This last slide I've got actually comes from New York City. Looks at quite a, as you know, that's really where the pandemic has really hit the hardest. And this shows you COVID positive patients in New York City. And these again are transplant recipients, 596 transplant patients across all organs, kidney, liver, heart, lung, and multiple organ transplants. And you can see here a mortality rate, 64, so about 10%, so not quite as high as the slide I just showed you, but a substantial mortality rate and probably higher than what we see in the community. So that was the last of my slides. I'll stop there, and happy to take questions or commentary, and thanks for listening.
Thank you, Peter. I think we'll have questions after presentation by all speakers. So we request Professor Allen.
So I hope that you can see my presentation.
Professor, you can click on the full screen, the slideshow button.
Slideshow at the bottom.
Bottom, sir.
Yeah, can you see it?
Yes, sir. Yes.
Good. Okay, so I'm going to talk about lung transplantation in the shadow of COVID-19. And having anticipated the sort of slides that Peter McDonald, my old colleague, might show, I've taken a slightly different tack, and we'll be talking more about the virus. I have a number of conflicts of interest to share. I sit on a leadership group for the National Clinical Task Force. I chair a DSMB, and we've submitted a trial to the Medical Research Future Fund to attempt to cure COVID-19, but haven't been heard whether we've been successful yet. So the symptoms you will all know, but I'll mention one particular symptom which is very interesting, the loss of smell and taste. And by the time people develop dyspnea, they are in trouble. The majority of patients may have very mild symptoms, as Peter mentioned, but they then develop tachypnea, tachycardia, respiratory failure, and fulminant hypotension. How do we diagnose it? The best test that is currently available is to use a multiplex PCR, which has two COVID-19 genes attached to it, using a same-day service, and at St Vincent's they do 3 runs per day. The best test depends where the virus usually has the highest amount of viral load, and that's in bronchoalveolar lavage fluid, but there are risks of that which we'll come to. Nasopharyngeal swabs are the more commonly performed tests, but they have problems with sensitivity. Only about 60 to 70% they have a large false negative rate. Throat swabs and sputum have an incremental role. The true place of the point of care assessment of IgM and IgG antibodies is not known. And once again, these tests, which are coming into vogue in some areas of the world, have not been validated yet. This is how you do a nasopharyngeal swab. And there's a lovely video on New England Journal's site, which shows that firstly, you have to have adequate personal protection. The patient should be wearing a mask. Note that none of the other equipment is covered here. And you perform a posterior nasopharyngeal swab. I would take some exception to this video because it's usually better for the patient to have their head exactly horizontal, so that you don't have to judge the angle in which you insert the flocked swab, and then the swabs are sent off. This is a straight line, and the flocked swab that you'll see here actually is slightly bendy at this end. But that is risky to the person performing it. This shows you the spatter of particles that occur on the face shield of somebody doing an intubation, a bronchoscopy, or indeed if you're standing in front of somebody who might be coughing. It is risky for the operator, so you need to wear the appropriate equipment. Similarly, and this explains why people with a sneeze and people with a cough must take hygienic precautions. Large droplets will rain out about 1 to 2 meters away, but the gas cloud, the turbulent gas cloud here, can travel for 6 to 8 meters around the room, so that although we say stay 2 meters away from somebody, if you're in an enclosed space with somebody with this illness who sneezes, then you can die from it. Even talking is not safe. These are visualized speech-generated droplets shown with laser lighting. And there are 2 graphs here. One that shows somebody talking here, the number of flashes, when they're saying a particular healthy, the TH of healthy. But down here, see this flat line? If you just put a damp cloth over your mouth when you talk, then you don't get any flash counts. So talking also is dangerous to our health. The stability of SARS-CoV-2 is very, very important for transmission. Basically, it's quite similar to CoV-1, but there may be epidemiological factors of the two viruses that, including higher viral loads in the upper respiratory tract, which lead to increased infectivity of CoV-2. Now, both aerosols and fomite transmission is quite plausible, since the virus can remain viable and infectious in aerosols for hours and up to days on certain surfaces, depending on the amount on the inoculum. And once again, a lovely article in the New England Journal. And if you want to compare CoV-2 with CoV-1 here over time for different surfaces, aerosols, copper, cardboard, stainless steel and plastic, you can see that it hangs around for a long time, 80 hours here, but less on copper and less on cardboard. But hard surfaces, it will stay around for a long time. We'll just move to a slightly different concept. In cold weather, of course, these viruses like cold weather. Once you get up to 40 degrees centigrade, they degrade. Peter has talked to you about the local Australian Transplantation Society. I'm going to share with you some of the international guidance. Now, with donors, he's already mentioned that we need to avoid high-risk donors, always balance risks and benefits for the individual recipient and for the team, and check the status of COVID-19 at least once, if not more. We don't recommend that patients who are actively infected stay on the wait list. They should be off it for at least a couple of weeks and have several tests to demonstrate that they are no longer actively infected. At this stage, there is grave concern about actually transplanting anybody who is actively infected with COVID-19. However, that is not to say that somebody who has recovered, no longer has live virus, who has developed ARDS may not be transplanted in the future. And Peter's mentioned the risk of myocarditis in that situation that should be considered. There should not be any change in induction therapy. And of course, COVID-19 is also associated with lymphopenia. But we may need to consider prolonged post-operative care and the risk to the patient in an ICU, particularly if that ICU also shares COVID-19 patients. So it's a very complex situation. It depends on your local situation. How do we treat COVID-19? Peter's also mentioned some of these, and we'll go through these one by one. There actually is no evidence to support the use of prophylactic therapies, specifically chloroquine and hydroxychloroquine, outside of a clinical trial. And the clinical trial data to date emphasize the risk and the toxicity and drug interactions over benefit. Supportive care and oxygen delivery systems is also up for consideration. Now, we were at one stage recommending early intubation, but that is being under review. Of course, early intubation may reduce aerosol generation from the patient in ICU, but we need to have in each centre local guidelines on criteria for both mechanical ventilation and other forms of oxygen support. We mentioned that the antimalarials, they're under review, but there are no data demonstrating superior efficacy. And one must always consider the known toxicity of these drugs. Plus, one of the negative effects is that if we use these drugs, holus bolus, then those patients who may get real benefit, our patients with lupus erythematosus and the like, will not have any drug to use. There is some evidence about remdesivir, an antiviral agent which has in vitro activity against SARS, and it's in multiple clinical trials. Compassionate single use is no longer available in most countries, but thankfully the risk of significant drug interactions seems to be low. There is no good evidence to say that combination antivirals against HIV are currently suitable for transplant patients at this stage until we demonstrate that in trials. Now, the anticoagulation rationale is quite complex. One of the reasons that patients with this condition die is due to sepsis syndrome and cytokine storm. What that does is it propagates DIC, reduces serum levels of AT3. Therefore, with this derangement in coagulation profile, the majority of people would think very seriously about prophylactic anticoagulation, either with low molecular weight heparin or heparin, unless there is a real reason not to. Interleukin-6 inhibitors have been used in a number of off-label clinical trials and also in clinical trials, and particularly tocilizumab. And there's anecdotal evidence to suggest that it may be very helpful. But the anecdotal evidence also suggests that you need to use it early, not as a part of a rescue fantasy, not as salvage, but in a planned way for those small percentage of patients that develop, that are developing the syndrome. I mentioned to you this this website, which I don't have time to go through today, but it makes a cogent populist argument for the use of masks for everybody at every time that you see anybody else. And the evidence that I've presented so far suggests that that may be a good idea. Peter's mentioned what happens in Australia. I just want to mention that the majority of patients that we've seen are young. Why is that so? Remember, these confirmed cases are symptomatic. It may be that young women in particular are more likely to present with symptoms than young men, or that these people are more likely to have social congress. However, as Peter's mentioned, the mortality risk goes up much higher in those over the age of 70, and this is a worldwide trend. One of the problems, of course, is this group here of locally acquired infections, and where a contact cannot be identified. The problem there is as that grows, we reduce the chance of suppressing or indeed eradicating the virus from our community. Sometimes it takes the wisdom of our neighbours to help us with these things. Peter's discussed the mild, moderate and severe breakdown of the disease. Severe, of course, is that group that end up in hospital, often needing ventilatory support. And these are, this is a rough diagram demonstrating the numbers of patients that go into each group. About 25% of patients may be asymptomatic, but they are still infectious. And the problem here is that they may not be able to be diagnosed and suppressed. If the ICU, the hospital, only has 5%, then we can cope with that. But by the time that 15% of a larger number occurs, the hospitals are overloaded, as we have seen overseas. How do we slow that? And I make no apology for going through these. Good hygiene, soap and water denatures the virus, social distancing and self-isolation. And this is what's happened to the curve in Australia. As we can see, what will happen out here, nobody knows. The hot topics are eradication versus suppression. Well, perhaps it's part of a continuum, but we need to test all, trace all, and treat all if we had a treatment, vaccinate all if we had a treatment. And it reminds me of the Rubaiyat, the brave beating of a distant drum. Hopefully that drum beat will become closer. Now, there are multiple candidates for vaccines. Human trials are just beginning to enroll. no data have been generated. And one of the problems, as we saw in COV1, is the risk of exacerbating the immune response. We don't yet know the cost benefit or the risk benefit. We need to watch this space. Herd immunity is often talked about. It may be natural or versus vaccination, and certainly it will slow the new acquisition rate within a community. But if 40% of the community need to develop antibodies, that may lead to 50,000 to 100 deaths per million head of population, which of course will cause a vast consumption of healthcare resources. Immunity may not be durable. For example, we don't have robust vaccines to RSV or other coronaviruses, and mutations may need a similar approach to influenza. But one of the evolutionary trends of a virus is it does depend on living hosts, so there is evolutionary pressure towards lower virulence. Do we have any designer drugs? Is this our best hope? If we had a suitable cost benefit and could treat all cases and contacts prophylactically within a universal healthcare system, which paid rather than user pays, we may be able to control this virus henceforth. We need to watch this space. There are a lot of other potential cures which I'll pass over because they don't work. But there's a good source, the American Society of Hospital Pharmacists COVID-19 Drug Resources, which is a curated source to be able to, if you want to look up any particular drug. The New England Journal had a lovely editorial about how we should evaluate drugs during the pandemic, making the point that if we simply give everybody drugs that have unknown efficacy and unknown side effects, we shoot ourselves in the foot. We don't have the ability then to use proven drugs to patients who really need them. And I'll finish with this. If we relax pandemic measures too early, perhaps the same thing will happen as happened in the 1918 pandemic strain of influenza in Denver. Cases were falling down, interventions were removed, and a lot more people died. So, do we learn from history or do we not? And I thank you for your consideration, and I'll stop sharing there.
Yeah, thank you, Prof. Alan. I think Prof. Detalle will be.
Actually, I can't hear you, Kumud.
You said yes. Can you hear me now?
Yes.
No.
Can hear you now.
Yeah, now I can.
So I'm going to, can you hear me now?
Yes. Yes, Kumud.
Okay, thank you. So a bit of the surgical aspects related to COVID-19 in terms of transplantation and mechanical surgery support programs. Just going through very little of the background, some of which has been covered. In terms of the surgical team and what changes need to be made, any novel practices in terms of donor-recipient selection and matching, the relevant logistics around retrieval and how the pandemic has influenced that, any changes that we need to make in the actual operating theater, and very briefly on the MCS program and what this might mean going forward. So we know from just looking at the previous pandemics, not least the H1N1 back in 2009, that certainly patients with chronic lung disease, pulmonary conditions are at increased risk, not just of morbidity, but certainly even requiring ICU ventilation and mortality. In that particular instance, we had a very high use of ECMO, which doesn't appear to be the case at the moment. And in fact, ECMO may actually be detrimental. There's certainly no evidence that there's increased risks that the current COVID-19 caused by the SARS-CoV-2 infection carries any greater risk, but it's just assumed in respect to solid organ transplantation by virtue of their immunosuppression, and certainly similarly across to patients with in situ devices and those with pulmonary vascular disease. If you look at both the SARS and the MERS data, certainly there's vulnerability in those patients with morbidity and mortality in patients who have got hypertension, who are smokers, diabetics, and with cardiorespiratory disease and chronic illness. And most of our patients, of course, have those. The primary thing here is it really requires an enormous mind shift, not just in terms of a department, but really corporately in the hospital. That's really got to come together. And the cardiothoracic elements here really need to have this under the senior leadership on a daily basis. Prepare for the worst always and have surge plans in place, despite the fact that there are many areas that are fairly quiescent in terms of patients in the ICU setting. We don't quite know what may happen. You need to have contingency plans and the ability to adapt rapidly, but safely. I think staff and patients require frequent updates, and this is clearly difficult when you can't have big gatherings, but it is imperative that these take place. And finally, that in this sort of stressful situation where many units, particularly those hard hit in the metropolitan areas, where staff and a bulk of patients are COVID positive, that there are going to be quite a number of staff that are in isolation, self-isolation or quarantined, and all that compounds into a stressful situation environment. And so I think the mental health and quality of life of your colleagues, and particularly junior staff, is paramount. Clearly, to cancel, minimize all meetings, go to whatever you can without meeting, cancel visits, reps, that includes reps and other personnel coming to visit, and non-essential educational programs as well. I think the other aspect that's really crucial is in this crisis where many patients are being readmitted for heart-lung failure, post-transplant, post-VAD via the emergency department and not necessarily through the dedicated clinics, then there is a chance that these patients, if they have symptoms or fever, might get put into under respiratory medicine or in a COVID ward if they're due positive. And so they might come with a fever, but the fever may have nothing to do with infection with COVID, may have something to do entirely with an infection elsewhere or harboring a rejection episode. And people looking after these patients in that context may not be those ideal patients. So you need to have extra vigilance from your teams in making sure that those patients' admissions are informed very early on. Otherwise, there's a good chance of missing on them. This, I think Peter's already been through. And having noticed this, there is, in the Australian context, the possibility that things might, as Peter suggested, relax a little sooner. I would suggest that these sites that you can go on to have actually got very good pages for COVID-19 related to transplantation and retrieval services. And the British Transplantation Society in particular has got a really good link on its site for a library of general and organ-specific literature that's come about in these last few months. And it's a really good place to go to try and update yourself, apart from the general pages in all these associations, and you'll find one that suits your particular niche. So let's just go through some basic principles of how we're assessing what you can do. And despite international, national society recommendations and government and national organ procurement and transplant association recommendations, you have to really evolve your practice based on where you happen to be, what the local community impact of COVID-19 is, what is the impact in your hospital, are there ICU cases on ventilators, are there safe areas in ICU if that is the case, what is the testing capacity in the hospital, the availability of PPE, particularly in more the lung transplant area and for pulmonary physicians doing bronchoscopies, and of course the availability of blood products and potentially ECMO services. So the surgical team really is one of availability, again, because some of these staff may well be in isolation. It is recommended that perhaps you can, if you can manage it, is to split the teams, as has certainly happened both at the Alfred in Melbourne and at St. Vincent's, whereby the routine cardiothoracic in Sydney is happening, routine elective cardiothoracic surgery, those that need doing are happening in the sort of private hospital, and the rest in the public, which is doing more of the transplant work. And so the teams are split, and to try and have reserve staff that you can call upon. Some units are very fortunate in having doctors and physicians who are qualified but are doing research for the time being, and then they can come in and pick up the pieces or double up or replace if necessary, or provide that second retrieval service, which is of great value. So in terms of donor selection, I think we should generally expect from the recommendations that there might be fewer donors, because you need to know what is happening in the donor hospital and what the resources are there. That the donation might well be delayed, not only in terms of identifying the suitability of the donor, but also in making sure your recipient is also negative. Try to avoid the marginal extended criteria donors if at all possible. And this is more to do with the impact on ICU resources, and therefore increase also risk of potential infection subsequently. It goes without saying that the waitlist patients should be tested negative. What is the recipient's prognosis? This should really be a multidisciplinary decision, and always the question that can it actually wait? Is that recipient really within that 3 to 4 month period of passing away if they don't receive a transplant? And of course, the recipient needs to be informed of the situation. They will be very concerned and want to know whether they're going to be able to survive both a transplant and the virus infection. And that is really crucial to be able to involve them in that decision-making process, and not necessarily to penalize them if they wish to defer. In respect of the logistics of retrieval, as I mentioned before, from the recommendations, and Peter reiterated this, which is to try and restrict initially the donors that are local. Try to avoid and reduce certainly the interstate travels, because that is likely to increase the potential of spreading the infection. If you can have separate teams, all the better. And if you can separate your retrieval team from the transplant team, that's even better still. You want the minimum amount of staff going out on the retrieval team, so all visitors and other people who want to view should not be really going on these runs. The donor obviously must be tested and be negative, and the history of that donor becomes even more important in respect of the recent travel, contacts, and so forth. What is the COVID prevalence in the donor hospital, and particularly in that ICU? What about the staff in that hospital? And are there COVID facilities that are dedicated in that donor hospital, whereby you might be able to be reassured that there's less risk of contamination, and maintain very strict hygiene protocols? Now, the issue around the donor hospital and the donor is that we don't know what the rate of false negative testing is in the donors. We know that the ideal at the moment is PCR of nasopharyngeal swabs, which has a reliability of around 90% plus, whilst if you just do a basic BAL, you're down to 65 to 70, sorry, the other way around. If you do a BAL, it's over 90, and if you do a nasopharyngeal swab, it's 65 to 70% reliability. And of course, because the viremia tends to be very low in this condition, reliability purely on a blood PCR is not of much benefit. What about the operating theatre itself? Clearly, it helps for those who've got dedicated cardiothoracic and transplant theatres. But the transplants are really done. And despite all the numbers that we've seen and this, the situation is very different from one hospital to another. So while in Melbourne, it's a really huge hospital, in the public hospital with no private attached, it's still going on because of the ability to split teams and have dedicated theatres. While at St. Vincent's, it's a little bit, in a sense, easier because you can move a lot of the elective to the private setting and dedicate the public services purely to transplant and the riskier procedures. So as Peter mentioned, Sydney has in fact taken up the interstate donations and traveled where necessary, particularly where we can't rely on the local teams to procure. And here it really is one of not the procurement so much, but it's really one of managing and putting the DCD heart onto the OCS device and then maintaining its viability and support during the transportation phase, and being able to assess that heart ex situ and make that decision about whether to proceed with the transplant or not. And for that reason, St. Vincent's is having to go and travel interstate where necessary, but these are really made on a case-by-case basis, and really absolutely when the donor is clearly of very good quality for that particular recipient. Where you can, and it's not a DCD heart transplant, but more of a routine in terms of a brain-dead donation pathway donor, then you rely increasingly on local retrieval teams. And again, the St. Vincent's Hospital has been very successful in relying on new retrieval services, for example, whereby physicians, surgeons who have had previous experience in transplantation but no longer are in a transplant hospital or no longer carry out any transplantation can be sort of brought back in to do that retrieval service, which really means you limit the amount of travel time and use local expertise whenever necessary. And I believe Peter will correct me, but I believe that's recently happened with hearts coming out of Adelaide. So this is, I think, from Stanford, really about what happens in theatres and the pathways. And this is very much what's practiced, but this in the Stanford have actually gone and written it down as a sort of a protocol, how they do it in respect of avoiding the contact and the possibility of spread of infection when you wheel the patient in various areas and going into theatres, how you avoid parking in the recovery bay or even the anesthetic bay, but to go straight to theatres, so everything is already in place. And for extra vigilance for the anaesthetist, particularly during the intubation time, and you can follow that link if you wish to actually look at the paper itself. But it fits with very much what's already in many of the society recommendations that I alluded to earlier on. And here, this is again, just to carry on a little bit further, what they're doing in terms of testing for patients. So as you'll see here, everybody does get tested, and then you decide on whether to go ahead or not. And the testing really becomes really important for those urgent cases, which we would put transplantation and mechanical support implantation into that category. So the MCS program is going ahead in both the units that I've been associated with, but it's again on a case-by-case basis. Patients must be tested negative. The usual precautions, the use of heavy-duty PPEs, apart from what we would normally do in theatres, is really dependent on the availability of that. And you need to watch out, as I mentioned again, and I don't make apology for repeating the diligence that you need to have amongst your team to make sure that you know about any readmissions where they are, whether it be for a transplant or a post-bad patient who may actually have a problem with their pump. And of course, to try and increase contact with telehealth. Now, if you look at the world sort of pandemic, and Peter put up quite a few slides to explain what's been going on. When you look at Australia, its number of ICU beds is somewhere around 9 per 100,000. And the expected course was to have been that in the bottom right, where if it had happened at a rate of 5% utilization, you would have gone up above this, where at a case of over 45,000 or so, we would have breached any ability for ICU resources to deal. In fact, as Peter showed you, the number of cases way down. It's only at about 6,000. So for some reason, I think the social distancing, the testing, the quarantining had made enormous impact, certainly in reducing the numbers, as you see here, which again is that same one I think Peter showed you from 2 days ago. The composite numbers here of only 6,000, 6,500 cases, and only 74 deaths in Australia. And this is, now Alan briefly mentioned this, which is that what happens in terms of relaxation of complying with social distancing is that if you don't have it beyond the 70% and near 80, ideally 90, then there is an expectation that you're going to actually have a very significant increase, almost continuing with that exponential rise that we've seen in terms of the pandemic getting worse. And so whilst we are reassured that in transplant patients, there isn't, in terms of numbers, and those numbers are small, that there isn't any greater risk, I would just caution that because the numbers are small and that we may not necessarily see the peak definitely has gone away, and it'll come back if we don't maintain vigilance. And there's a variation in the projection of how long that should continue for, which ranges from, in the UK, they're suggesting till the end of the year, to other places where the relaxations are just slowly coming in. In Sydney, you can now finally go to the beach, but only to exercise, for example. And as we heard from Peter, that some of the kidney transplants might come back in sooner. I think it's imperative, if we're going to talk in the Indian context, of just to mention that it is really vital to, not just in the case of the COVID, but in general for transplantation to have really good prospective data. Now, right now, this is imperative because we really need to know what's happening for continued management of these patients. We don't know what happens to people who are infected in respect of their acquired immunity and how long that may last for. And certainly there's suggestion that the reinfection rate is surprisingly high early on, even in patients who recover from COVID-19. And so it becomes even imperative to keep a very close eye on patients who are readmitted post-transplant or MCS implantation, and to collect those variables, which I don't need to go through, in respect of having appropriate data. And what about the future? Well, I think the positive cases are declining, but there's no evidence that, as I mentioned, we should be reducing any vigilance, and that goes to really complying with national and or your medical society recommendations. We do need to collect prospective data, and not just collect, but to share, to register and collaborate in evolving what we do as evidence-based medicine in transplantation and MCS. It's likely to confer certainly very, I think in the long term, extra vigilance in the lung transplant cases. The SARS-CoV-2 now is going to be part of a yearly cycle. It's here and it'll keep coming back. And so we do need to be extra careful. Consider perhaps dedicated retrieval teams that can look after the various centers in the long term. A case made for a more dedicated, more specialist operators, and increase transplant resources and train dedicated staff, and perhaps even a case for fewer and higher volume centers, given the cost of establishing these centers, given we know of the relationship between volume and outcome by looking at INSHLT database, and how it becomes easier also to teach and train, and that when we do get pandemics and crises such as this, that the economical consequences also limited. And I think I'll leave it there and answer any questions that there might be.
Thank you, Dr. Kumud. I think Dr. Sarvesh, can you come on with your presentation?
A minute to share the screen. 1 minute.
Yeah.
Is my voice audible?
Yes, yeah, quite nice.
Okay. So I would be discussing about the INHLT guidelines or the recommendations that the INHLT has given to NOTO. A little background: we all know that in December 2019 there were a lot of unexplained deaths in Wuhan, People's Republic of China, which was subsequently attributed to SARS-CoV-2. Following which, on 11th March, WHO declared this as a pandemic, and on 24th March onwards, India went into a lockdown. The Indian Society of Heart-Lung Transplant on 29 March constituted a task force of some eminent members of this fraternity to develop some recommendations or to develop a yardstick to go further on. This was 2 days back when the WHO Director General Tedros Adhanom Ghebreyesus commented that this virus is going to stay for a long time. So whatever recommendations we are giving or we will be giving in future, it will have to be dynamic. So today, like the Australians are meeting every week and the International Society of Heart-Lung Transplant is meeting every week. We will also be updating these recommendations after 2 weeks or 3 weeks. The Director General of WHO is a microbiologist. I'm not sure how many people actually know that. And he has the maximum research on malaria. So I think we should believe him when he shows that hydroxychloroquine is not going to work. This was published today in one of the leading dailies of India. If you read the headline, that it appears that all the heart transplants are going to stop. But if you read the fine print in which our director of NOTO, Dr. Vasanthi Ramesh, has clearly said that it is not a full stop or 100% ban on transplants. Patients who are sick will undergo transplants. Now, the recommendations which were given to the NOTO, I think last week, a summary of this goes like this. Till now, we don't have any evidence that recipients of heart-lung transplant are at increased risk of developing COVID-19 disease. There is insufficient data that recipients who develop who get infected will develop a severe disease. Dr. Peter McDonald showed a slide in which he showed that the heart transplant or lung transplant recipients who develop COVID-19, the mortality was approximately around 20%. But the same is true for patients who have gone on ECMO. The mortality is in ranges of 60 to 70%. So patients who are developing severe disease otherwise also have got very high mortality. Therefore, the Indian Society of Heart-Lung Transplant does not necessarily recommend a general cessation of transplant activity. However, this should always be weighed on risk-benefit analysis of performing the transplant versus the risk of COVID-19 infection and in terms of the mortality or the morbidity the recipient may carry if transplanted or not. The number of resources which may be utilized. Dr. Detalle just now mentioned that if yours is not a COVID-19 ICU and you have beds to spare, you may go for a transplant. But if you have a COVID-19, don't have beds to spare, there's no point of discussing these recommendations. However, the recommendations which we made, and I think a lot of societies missed a very important point about the legal or the ethical implications of these recommendations at a later date. The International Society of Heart-Lung Transplant has come up with a new document considering these ethical considerations. Probably in a later date, we will also come up with something like that. The recommendations for waitlisted patients who are not admitted, there is no prophylaxis recommended. The testing for these patients is recommended on the basis of contact history, either with a COVID-19 positive patient or with a positive healthcare personnel in past 2 weeks. All the patients who are symptomatic should undergo testing. And if the tests are negative, they should consult a physician or a COVID-19 special hospital before undergoing a repeat test or before being discharged. Although if these patients come positive for SARS-CoV-2, they should be taken off waiting list. This is in consistence with the INSHLT guidelines only for a minimum of 14 days. If they are asymptomatic, the transplant should maybe deferred for a minimum of duration of 14 days, and then the physician may decide whether to put them back on waiting list or not. Now we have antibody tests coming up, so we can, if they were positive, we can actually see the antibody titers and decide that. But when these recommendations were made, the antibody tests were still not frequent. However, if the patients are symptomatic and COVID positive too, the minimum duration of difference from surgery is 14 days, and it may be decided by the operating surgeon or the team leader to defer it more, given the situation. The recipient should be waitlisted again only when he or she tests negative for on 2 occasions, 48 hours apart. Like I said, that when the transplant is unavoidable and necessary, we should ensure these things before putting the patient to NICE. There should be an absence of recent exposure to either COVID-19 positive patient or such patients attending. There should be an absence of travel to any high-risk states, specifically like Delhi, Maharashtra, even a couple of Gujarat now. There should be absence of symptoms compatible with COVID-19 in previous 2 weeks. In case of suspicion, the reverse transcripted PCR test is recommended on nasal or nasopharyngeal secretions for all recipients who are about to go transplant. And it would be wise to repeat this test within 24 hours of transplant before the patient goes to the OT. All patients who are on ECMO and are transplant candidates should get COVID-19 testing done on 2 occasions at least. And if COVID positive transplant, due to lack of data and due to lack of understanding of the disease, it is as of now recommended to avoid transplant in these patients. Regarding consent, the INSHLT recommends that transplant team should have a discussion of risk versus risk benefit analysis with the recipient as well as the family members. And all the transplant henceforth during the COVID era or during the COVID pandemic should have a video consent recorded for later uses. It should be clearly told in the consent that even when the patient is, even when the recipient and donor both are COVID negative, there is a slight possibility that the recipient may develop a positive test later on. We should remember that the tests which we are using and the kits which we are being supplied, this is the statement of Dr. Ganga Khedkar, who is the director of ICMR looking after the COVID-19 pandemic, that the kits we are using, especially they are being imported from China, and the sensitivity at best is 80%. So there are cases which are likely to be missed. Perioperative recommendations are same like the other societies of Australia, International Society of Heart Lung Transplant. There is no change recommended in either induction protocols, in perioperative management, or alteration of immunosuppressive drugs and their doses in patients who are COVID negative. Regarding the donor, certain high-risk donors are to be avoided, and this is for future purposes also. Donors who are residing either in hotspots or areas where local SARS-CoV-2 transmission has been occurring or has been reported, exposure to a probable or a confirmed case of COVID-19, and a compatible clinical syndrome, regardless of known exposure within the past 14 days. When to test the donors? The consent for testing for a coronavirus should be taken at the time of the donation. The sample can be taken at the same time as it is done for other viral markers. If possible, you can take tests. You can take samples for both type of tests, the RT-PCR and antibodies. RT-PCR is the preferable test, and like my previous speaker said, that BAL would be a good sample to do it in an intubated donor. Testing, the INSHLT recommends the testing to be done preferably in the nearest government approved lab for first for information, the statistics, and then the trust issues. If COVID positive, there should be no organ donation from this donor. My slides have gone on. The INSHLT recommends high resolution chest CT for all desirable organ donors, for all thoracic organ donors, as an extra precaution. We understand that it is not possible in resource limited settings, especially in hospitals in India. But given the situation and the dire need of extra precaution, it is desirable to have CT before harvesting organs from such donors. For all lung transplants, like Dr. Allen said, that observe the patient. It is recommended to observe the donor for a small period of time before harvesting. We recommend doing HRCT for all potential lung donors. Any recipients who develop COVID-19 disease and are symptomatic after their transplant, it is recommended to stop antimetabolites, decrease the dose of calcineurin inhibitors, and continue steroids, because there is a slight theoretical advantage of using steroids in patients who are developing chest disease as well. However, we should keep a close observation for development of rejection. All the routine biopsies may be deferred for 2 to 3 months in asymptomatic patients, and the planned visits of all the recipient or the follow-up patient should be taken care of by teleconsultations, like we are doing for all other patients. This data collection, which I think Dr. Detalle also recommended, and it is a standard format of INSHLT. We also recommend the same format to maintain data henceforth for collecting and using information at a later date. This is the first case report published of a post-heart transplant recipient who developed a COVID-19 disease. His stay approximately was 30 days in ICU. The patient got off without any intubation or mechanical ventilation with supplemental oxygen. However, you should keep in mind that in this patient, there was a 30-day ICU stay before he started recovering. So if infected, these patients will be there in ICU for a prolonged period of time. I think that finishes the guidelines. Thank you.
Thank you, Dr.
Thank you, Sarvesh. Now we'll have a few invited faculty who would be commenting about their experience and situation in India. I request them to restrict themselves to within 5 minutes. First, I request Professor Sandeep Seth from All India Institute of Medical Sciences. In fact, he's one of the beginning transplant cardiologists in the country working in All India Institute, where they did the first heart transplant in this country. Professor Sandeep?
Yeah, thanks, Dr. Gokhale. So I just made some notes on this. One thing is clear that if a heart transplant patients get COVID infection, from whatever little data we are seeing from New York, the mortality is going to be high. The New York data suggests that if these patients get COVID, if they get admitted, then the mortality from their data seems to suggest at least a 10% mortality. But on the other hand, whatever data Dr. Peter presented, whatever data we have from the Chinese publications, the risk of infection for these patients is pretty low, because most of these patients anyway have been taught social distancing. They all practice social distancing, they practice hygiene, they always travel with masks in crowds. So they were already taught social distancing. So that risk of infection is pretty low. Now, looking at our experience from India, we have about 26-27 patients who have been staying in and around Delhi NCR, and they have been following up. What we have been doing is that we have linked them up to telemedicine. So they come to us only when they really need to come. And at the moment, there are only 2-3 patients who really need to come. So what we did before the lockdown actually got imposed, we called most of the patients in, we gave them a 2-3 month supply of medicine. And whoever were distant, we told them quickly build up at least 2-3 months supply of medicine, because the medicines are going to run out. We told all of them to at least build up an extra dose of steroids, because if your other medicines run out, you can at least maintain yourself on steroids. And that is what seems to be happening now. Quite a few of the patients are running out of tacrolimus, quite a few patients are running out of Cellcept or mycophenolate, because it's not being available in some of the distant chemists. So we're telling them to, if necessary, reduce the doses and just increase a slight amount of steroids till we can somehow get the doses to them through a courier or through one of the relatives who's staying in Delhi. So this is how we're trying to adapt to the lockdown period, because it's getting actually difficult for some of the patients to get the medicines. What we're also doing is to somehow give them travel passes using WhatsApp. We write down the patient's name, write down their ID number, put their photo, and WhatsApp a travel pass to them by which they can travel to us through the police barrier, so that they can reach us to get medicines through us if they can't get medicines through the local chemist. So these are small ways by which we're trying to adapt to help some of our patients. And this is what we've been doing to help some of our patients. So that's our experience with our, so far none of our patients have actually got COVID-19. So our patients have been pretty safe as far as the infection is concerned. That's
Thank you, Sandeep. I think we'll request Dr. Vijil Raghavan. He is a transplant pulmonologist from Chennai. Their team does one of the largest number of lung transplants in the country. Hi, Vijil.
Thank you, Dr. Gokhale, for giving me this opportunity. First, I would like to thank all the speakers who gave a very excellent presentation. And from our experience, I would say that we did send out communication to all our patients. We have over 120 lung transplant patients in our unit whom we follow in a very regular way. And we still don't have any infection on any of them. So we send out a circular when the initial guidance came from the ICMR to stock adequate levels of immunosuppressive medications as well as to provide adequate supply and to get a good the only other extra recommendation we made was to prophylactic use of hydroxychloroquine patient but I think right now there's not much evidence in that practice. But we did give a recommendation at that time. I would also ask the panelists here, maybe they can answer this question later on, because when we start resuming the transplant, there was some data that if we in the operating, they will tell you that operating with a PPE is extremely uncomfortable. But however, I did come across some data that the risk of aerosolization is very less after 1 hour after induction of anesthesia. So this question needs to be addressed, because after 1 hour in that case, they can de-scrub and go back to regular OT attire and then continue with the surgery. So this is something which we need to look into, because if we ask them to operate in a full PPE, it is going to be very extremely uncomfortable. Otherwise, so far we are monitoring all the patients to telemedicine, and so far we did not have any COVID infection in these patients. Thank you.
Thank you, Vijil. Now I request Dr. Balakrishna, the face of cardiac transplant of this country, to give his comments, please. He has the largest experience in heart transplants in this country. Of course, he's also doing a lot of MCS too. Bala, are you online?
I'll be very brief. As Dr. McDonald mentioned, the beginning of the year, we were quite busy. From the 1st of January till the 18th of March, we had, I think, done 19 transplants, 16 heart and 3 lungs, and 3 LVADs, which 2 were heart, 3 and 1 HVAD. And from the 18th onwards, the transplant activity is completely stopped. There have been no donors. Our local transplant authorities, the Transplant has said no. And today's Times of India has said, NATO has also said no. The other thing, of course, is the road traffic accidents have dropped drastically because no transport is allowed on the streets. Blood donors are less and blood is scarce. So even for emergency cardiac surgery, there's been a problem. We continue to do emergency cardiac procedures, genuine emergencies, which can't be put off. We've done, I think, 9 this month, including a child with LCAPA who's on a temporary mechanical support. As Dr. Vijil mentioned, I find it very difficult to breathe through that N95 mask and the visor. It's very difficult to operate. There's a lot of fogging, and breathing is actually near impossible after a while.
So, Baba, your voice is bit, can you come closer to the microphone?
Yeah, okay. Can you hear me now?
Yeah.
We have been awarding routine EM biopsies on patients who need them, and we've been asking patients not to come in. Fortunately, we have not seen any acute rejection needing a biopsy or urgent intervention this month so far. We've had one lung transplant patient on follow-up needing bronchoscopy and dilatation, which was handled with appropriate precautions. Of the transplant wait list, one patient died in the ICU waiting for an organ. 3 more are very sick in the ICU and 3 more are in the hospital, unable to be discharged, including one patient who went into a renal shutdown and is on regular dialysis. The tragedy in India is majority of transplant activity happens in private hospitals, so the bill is mounting. The patient and family are anxious, and their anxiety is a huge problem. We are having to constantly reassure them of our best efforts without sounding very convincing even to ourselves. What assurance can you really give to anyone? The other problem with starting major surgery, including transplants, is what happens if a member of the transplant team tests positive and all the contacts are quarantined. They could be left with no doctors to treat patients who have been operated upon. The other issue, which is again highlighted in today's Times of India, is hospital revenues are dropping. And if this persists for a few more months, what the future will look like, I don't know. With the economy in distress, there's certainly going to be a pressure in this domain, at least in the short term. The other tragedy we have personally faced is how to deal with patients who die waiting for an organ. Dead patients cannot be taken back to their own state for a funeral as there are no flights or trains. Even by ambulance, police clearance is needed. There's also an impression amongst lay public that dead bodies are infected, making ambulance movements more difficult. So the solution as of now beyond prayer, I don't know. So these are very uncertain times, and hopefully we shall overcome this in the next few months. Thank you.
Thank you, Bala. You raised very pertinent issues we are facing in this country. Now I request Dr. Sunil Shroff, is the President-elect of Indian Society for Organ Transplantation, to say a few words. See, Dr. Sunil Shroff founded Mohan Foundation, which is the first organ harvesting and distribution network as a non-governmental organization. And he has contributed enormously. And of course, later the government has taken up, and now the NOTO, and there is a regional agency like Jeevandan are doing extremely good job. Dr. Sunil Shroff.
Thank you, Dr. Gokhale, for inviting me to your panel, and asking to share my views. I'll only stick to 5 minutes, as you said. I would just give an overview of what's happening. Let me just share my slides 1 second, sorry. I may just. This is the one. Yeah, sorry. So the guidelines from NOTO and ICMR very clearly say that non-essential elective surgery should be postponed and only to take emergency surgeries. Disease donation transplant hospital decide depending on the urgency of the case, like acute liver failure and heart. And similarly, we have issued guidelines from our Indian Society of Organ Transplantation, and I will not repeat whatever the previous speakers have said, but obviously the clinical criteria are the same, that not to accept the donors where there are unexplained respiratory failure, fever, and so on. And there are laboratory criteria, as has been explained by the previous speakers. Epidemiological criteria is not valid at the moment because there's no travel happening for the last 1 month. And the routine testing for disease donors, we have suggested that a routine viral testing should be undertaken on all disease potential donors within 72 hours prior to donation. And also the immunosuppression, on that there are no standard guidelines at the moment available, but we have suggested that antimetabolites like azathioprine and mycophenolate should be not used, and decrease the calcineurin inhibitors and steroids to continue as in the same dose. So far, I also see Dr. Vasanthi Ramesh and Swanlata in the panel, and they will be able to say more on this, but I think the first case was discovered of COVID in January towards the end, and February to 15 March, most programs were functioning normally. After 15 March, we've only had about 6 donations as far as I know. Telangana, I think, did 3, Kerala did 2, New Delhi did 1. There was no interstate sharing of organs. And I actually spoke to some of the, I spoke to Dr. Noble Gracious. He said that patients in Kerala are doing fine. The Delhi transplants, just took place recently, so we're not very sure. Telangana, Dr. Swanlata, we should be able to tell you. Normally, we do 2 to 3 disease donations every day in India now, and the green are the states which do disease donation frequently. We have 250 hospitals, I think, registered, and of this, 108 are registered for heart and 63 for lung, but only less than 10% do it regularly. And these are the figures. I'm sure Dr. Vasanthi Ramesh should also share with you that since 2012, our disease donation rate went up 4.5 times. Today, we do close to 0.6 to 0.8 donations per million population.
Sorry, your slides are not moving possibly.
Are they not? Are you not able to see? I thought they're moving.
No, they're not moving. The same fixed.
Is it
Your
same for
slides are
everybody?
not moving. Yeah.
They're sitting on the disease organ transplant slide.
Did you see this? Sorry. Are you seeing this now?
We are seeing the diseased organ donation in India slide.
Okay, one second. I think it's just sharing screen which has gone wrong. One second, let me give you a full screen. Just one second. Resume share, yeah. See now, is it better?
No.
No.
You can click on the full screen button, sir.
Yes, I'm going to do that. Sorry, one second. I think I may have got it wrong. Share. Okay, I think this will be better.
Yeah.
Is that better?
Now we can see. Now we can see.
Okay. So, I mean, most of those things have been very simple so far, I've said. And, you know, as I said, since the COVID-19, we were doing normally till 15 March. But from 15 March to currently, we've probably done only 6 donations. And Dr. Vasanthi Ramesh probably will be able to elaborate more on this. And I spoke to some of the, you know, I spoke to Dr. Noble Gracious. You know, he said his recipients are doing one. We have done 1 heart transplant in Kerala. And apparently that recipient is doing fairly okay. We also done kidneys and livers in other states. So, and most of the recipients so far are doing well. None of them have got infected with any of the COVID problems. Normally, as I said, we do 2 to 3 disease donations every day in India. Obviously, this activity has stopped. And obviously, our numbers this year are likely to be low because of the COVID. We do have about 108 registered heart transplant hospitals and 63 lung transplant hospitals in the country, but less than 10% do it regularly. And this is the slide which I was trying to show you of how our organ donation rate has gone up from 2012, when we did about 196 donations, to 2017, when we did close to 900 donations by almost 4.5 times. And the heart transplant rate in India, by the way, is 0.22 per million population versus the global average of 2.4 per million population. And the heart utilization rate in some states like Tamil Nadu have been as high as 60%, is higher than the global average. And India's donor pool is maybe, as we know, age group of 20 to 50 years, mostly male. And with this, I'll finish my presentation, and you know I'll be open to any questions later on. Thank you very much, Dr. Gokhale.
Thank you, sir. Now I request Dr. Swarnalata, who is heading Jeevandan program in Telangana. She's a nephrologist. When she took over, there is hardly, the donation rate was very low in Telangana, but now she has taken it to the #1 state in the country by her drive. Dr. Swarnalata, please.
Yes, good afternoon, everybody. So I really thank Dr. Gokhale for providing this opportunity. I'm just sharing my slides. I have few slides to share. I don't know whether you can see the slides.
Yes, ma'am, it's coming.
And I also thank all these speakers who have shared their experience, particularly with respect to the Australia and New Zealand. So before I talk to my experience in Telangana, I just want to emphasize few other, the guidelines which we got, which was not discussed. So what I can see is we have to live with this COVID infection for a few months at least, and we have to evolve. And then the infection as well as experience with transplantation is increasing. So I believe we learn over a period of time, and we try to do transplantation. So it was mentioned in the American Society. Basically, the surgeries and the procedures was classified into 3 grades: grade 1, grade 2, and grade 3. And the transplantation has been put under grade 3, I believe grade 3, where transplantation have to be they have to be done. They need not be postponed. I'm just looking for the slides. I have prepared the slides for other presentation. I thought I can, discuss the important things. Yeah, this was the things. So they have been graded into 3 categories. The transplants comes under, the tier 3B, where transplant need not be postponed. It has to be done. So at least we can consider this in a, staged manner, not like, as a uniform guidelines that has to be done completely or not, but we can consider it as in a staged manner. So this is again where we can consider depending upon the local community spread, the hospital preparedness, and then the adequacy of the infrastructure, the PPEs, the transplantation team, and the ICUs, and prepared of the hospital to take up the COVID-free pathway. So it has been classified as 25% reduction, 50% reduction, and then 75% reduction, 100% reduction. In 25% reduction, we can actually do all transplantation, including heart and the lung transplantation. In 50% reduction of the transplant activity, we can actually do heart transplantation only the intermediate status patient, and lung transplantation we can, consider, but try to postpone if patients are quite stable. And then 75% reduction where we can, do heart transplantation only in highest status only, and the lung transplantation only when it is rapidly deteriorating. And 100% of the reduction when there is a shortage of ICUs, all manpower has been diverted to take care of the COVID patients. In that case, we need to completely stop all the transplantation activities. So this way we can, consider depending upon the hospital preparedness and the local community spread. So this can be followed depending upon the local this one. And the TTS has recommended that, particularly in a community spread has to be temporarily suspended. And that's what is being followed in most of the countries where it is local community spread is there, particularly in India also. So I think most of them have temporarily suspended their activities. And these are the few guidelines. I don't want to discuss all those things. And this is what I wanted to highlight again that, Singapore also, they have come up with another guidelines where they say that donor has to be tested for 3 samples at least 12 hours apart. And then if there's negative, and then they have to do a CT test also. If both are negative only, we can go for an organ donation. And toward the recipient, we need to have a 2 testing of the COVID with an interval of 12 hours, 6 to 12 hours apart. If the recipient is negative, only then we need to go ahead for the transplant. These are the few guidelines I thought I can add on whatever has been discussed by the previous speakers. So this is what is the existing guidelines so far. Again, NOTO has again come up with a certain guidelines where again they said it has to be temporarily suspended. And of course, they have given few, the consensus that depending upon the case by case basis, when we have a hospital has prepared to take up the transplantation activity and the patients are sick, particularly with respect to the liver transplantation and the heart transplantation, we have to do the testing of the donor and then the recipient. And then both are negative, and even if it is negative, there can be a possibility that 2 to 22% they can be false negative. So we need to take a informed concern that even if it is negative, it can be a false negative, or even if it is a true negative, there is chances that post-transplant, because it is we are in a stage of community spread, during a post-transplant period, he is likely to get an infection, and we need to explain the recipients and then only go ahead with the transplantation. So these are the guidelines which has been laid by the ISOT also. More or less, they emphasizes the same thing. And again, editorial has come in the Indian Journal of Transplantation. So they have also emphasized the same thing. So coming to our experience, so we had around 761 donations so far. As you can see, this year we had 30 donations and 4 heart transplantations. Coming to month-wise split, January we had 9 donations, February 11, and March we had 8 donations. April we have 2 donations so far. So if you look at heart transplantation were not done, even the kidney transplantations were not done, only the liver transplantation were done during the lockdown period. If you look at the individual the case based, particularly in the month of March, so we reported a first case of COVID in our Telangana on the March 2nd. So we actually had donations as per our regular rate during the early 2 weeks of March. We had around, I think, 8 donations in the March. So in the second week, we had a rapid increase in the cases because of that, the community, Muslim community where they had come from Delhi, and then suddenly 10 cases were reported. This is where the government has, was preparing the strategies, and government has announced that, government hospitals particularly should stop all elective surgeries and then they should be prepared for to take the COVID patients. By then, it was not decided which hospital to be taken for the COVID positive. So all elective surgeries were postponed in government hospital. That's why even though in March 19th, before the announcement of a lockdown, we had 3 donations. Then all the government hospitals declined the organ organs which were allocated to them, and all the organs were allocated to the private hospital. Here, kidneys, liver, and heart were utilized. So after 22nd, when the lockdown was announced, we had 3 donations. So during, immediately after lockdown, there was no clarity on, and there was no adequate supply of the testing also. So we could not do the donor testing and the recipient testing for the COVID. So we declined that donation. But subsequently, when the testing kits were available and more number of testing were done, so we had 2 donations in the month of April, and both the donor and recipient testing were done. However, for kidney, it's been temporarily suspended, so kidneys were not utilized, only liver were utilized. So this is about our experience. So overall, we had, after March, I can say the 15th, we had almost 6 donations, I can say. And during the period of lockdown, we had around 3 donations. This is the overall statistics. We had 30 donations in the year of 2020. So 11 donations from March 2nd. That's when we recorded the first case of COVID. And then after lockdown, we had 3 donations. And then the 8 donations were actually allotted as per the usual category, the allocation policy. And then only 3 donations we could not take it up in a government hospital, because government hospital was strictly told not to take up elective surgeries. And then 3 donations were declined. That's why it was declined in a government hospital. And 1 donation was completely declined because there was no clarity, there was no availability of testing kits. And then 2 donations where we have done a testing of the donor and the recipient, and then we could utilize at least liver transplantation, not the heart and the kidney transplantation. So what we thought is we have developed this protocol where if there's a potential donor, we can have epidemiological screening and the clinical screening. And the hospital can, if they have adequate resources and ICU and the staff, they can, and they have availability of the COVID testing, we can go for a COVID testing. If it is negative, we can proceed for the donation. If it's positive, we have to drop down the donation. If there are no sources, again, we have to actually, drop the donation procedure. And towards the recipient, so again, we have to look at the history, whenever the patients are being allocated because of the lockdown also, there's difficulty for the patients to, come to the hospital within the time. So, it's difficult to follow the absolute allocation policy. So we are trying to allocate, particularly whoever is ready to take the organ. So we are not strictly, I can say we are not strictly following the allocation policy. So we call the patients on phone when taking the history, whether they have upper respiratory tract symptoms. If they don't have symptoms, and they call the patients. And after our, again, we try to re-evaluate. And if the patient is fit, and then the COVID testing is done, if the COVID test is negative, you go ahead with the transplantation. But most of the time, what we have seen is because of lack of kits, we're not able to perform, and there's a turnaround time is very high. So we have, the retrieval time, and then we have to balance the retrieval time for the cold time versus the turnaround time for the testing. So here again, we are facing a challenge. So not able to get that COVID testing for the recipients. So another possibility is that, particularly it was suggested by one of the Italian, where we can go ahead with the CT chest, particularly I'm not talking about the lung and lung transplantation, at least for the kidney and liver, where we can have a CT chest. If there are no symptoms, patient is quite stable, and then there is the testing is not available, still we can go ahead with a CT chest if it's normal and transplantation, taking the, the informed consent about the possibility of the infection post-transplant. This is what we have evolved about the strategies for the transplantation. I think it will evolve as we have more number of experience, and then as we have to, deal with this transplantation and COVID, at least for a few months, as has been stated by the director of the WHO, that we have to live with the COVID infection. So I think it should evolve. Ultimately, what I would like to suggest is it may not be stopped completely. It can be, considered depending upon the staged manner, depending upon the hospital infrastructure, availability of the personnel, and availability of the testing kits. So we can take it up, but case by case basis and with extra precaution and the informed consent. Thank you. Thank you very much. If you have any questions, I am free to answer.
Thank you, Dr. Swarnalatha. And I request now Dr. Vasanthi Ramesh to say a few words. Dr. Vasanthi Ramesh is the director of NATO. It is the apex body which supervises the transplant programs in this country, and it is directly under the central government. Dr. Vasanthi Ramesh?
Yes, sir. First and foremost, I would like to congratulate Dr. Gokhale and the entire team for organizing this webinar, which has been very useful under the circumstances, because this COVID-19 is really evolving now, and every day the scene is different, and we have to, change our policies and guidelines as we go along. And as rightly pointed out by Dr. Swarnalatha, even the WHO has said that this is here to stay for at least a while. And therefore, though we had recommended temporary suspension, I think we would need to revise our guidelines to see how the program can go on, but at the same time, not putting, either the recipient or their families or the health professionals to a risk beyond reasonable limits. And the important thing is we would have to test the donor and recipient. Dr. Swarnalatha was saying that where it is not possible, if they are asymptomatic, if there is no history, we have evidence now from across the globe that there can be asymptomatic carriers and they can be transmitting the infection, and their numbers are likely to be significant, particularly in the context of India. So I think RT-PCR, at least 2 samples in the donor and RT-PCR in the recipient should be mandatory, so that the health professionals are also safe, in the sense subsequently they would not be blamed. As such, health professionals are subjected to a lot of hardship and harassment by the general public. We have even seen the case of a doctor who died due to COVID-19 in the state of Tamil Nadu, who could not even be given a decent burial. So I think we have to take it in totality and frame our guidelines. And many of you who have participated would be requested to join me in framing the revised guidelines, so that we make a single guideline which can be applicable to practically all the organs, with certain exceptions for liver, kidney, heart, and lung, so that there is no confusion. Because the first guideline that we have put up a general guideline, and then we also adapted the INSHLT and the liver transplant guidelines. But there are certain things where it may appear contradictory. So I would be glad if I could evolve a guideline which is common to all the organs, and with the help of experts from all the fields, so that there is no ambiguity, so that everything is clear, and we should be able to have it shortly, maybe in 2 weeks' time, after the lockdown is lifted. And the other thing is, it was very heartening to see data being furnished by Swarnalatha and Dr. Sunil Shroff and everybody, when we had written to all the states to furnish us with the data before and after the lockdown. The data received were, of course, Andhra Pradesh, they said that there were no transplants. Karnataka has not bothered to reply. Maharashtra, they have said they had 1 before the lockdown, that is in the period between February 22nd to March 21st, and 2 lung transplants before the lockdown, and they claimed that they have not done any after the lockdown, that is after 22nd March. Rajasthan again has had 1 heart transplant prior to the lockdown. Telangana has had 3 before the lockdown, but they said nothing after the lockdown period, that is after 22nd.
After lockdown, but I have sent you the entire data what I have presented. 3 is after lockdown.
Okay, 3 is after lockdown. Okay, I'm sorry. And Tamil Nadu has given that they have done 1 prior to the lockdown and they have said nil afterwards. West Bengal again has given 2 before 22nd March and nil after that. Kerala, of course, I read in the papers that they conducted a disease donor transplant in which also a heart was transplanted, though we have not received the data from them. And in Delhi, 1 disease donor transplant was done, but that was only for an acute liver failure. And because the kidneys were also retrieved, so the kidneys were also done. No heart or lung transplant has been done after the lockdown period. And my main thing is we should use this period, you know, like how this is a disadvantage for many things, but an advantage for many things. And most of us have time because we are not that busy clinically. So I would request each and every transplant physician and surgeon across the country to help us with complete data so that you have a scientific basis for everything that we propose to do from now on. So we will also get the formats made with the help of our Apex Technical Committee members. And I would request all the associations, whether it is INSHLT, whether it is LTSI, whether it's INSHLT or Indian Society of Nephrology, everybody across the country, that we, you know, we have now planned to have a lot of members in NOTO so that each and everyone feels that it is theirs, because it is not, you know, the person who's sitting as a director, it is not his or her personal property. It is the property of every doctor who is involved and every team member of the transplant team that NOTO represents. And therefore, the entire data of the country should be represented on the NOTO website so that it will be a window to the world of what is happening in the country and what our professionals are capable of. And it should be a very transparent system so that, you know, the people, whether they are in the country or those coming from abroad for transplants, have a, you know, one-click view of what is happening in the country. So I hope I can enlist the support of each and every one of you here. And also I would request you to, you know, convey this to all your colleagues in your state and in your associations and across the country so that we can achieve this. Thank you very much.
Thank you, ma'am. Thank you very much. You made it very crystal clear. Definitely on behalf of INSHLT, we members will definitely try to work with you along with the local bodies, with you also, because we need to show the world what is happening in India. Truly.
Just one additional point. Am I audible?
Yes, ma'am.
Yes.
I have been thinking of having a mathematical model based on which we can take this process further. So for that also, I would be very appreciative for inputs from all of you.
Sure, ma'am. Thank you. Now may I request Dr. Jignesh Patel, is it early in the morning there in America? Are you there, sir?
Yes, I'm here. Can you hear me?
We would like to hear from you what is happening in America.
Yeah, so in the United States, the situation is really changing by the week as it is across the globe. So there's not just a geographical difference, but a temporal difference as well. So while places like New York have been hit hard with COVID-19, in California, we have fortunately avoided the brunt of the disease. So we have not had the shortages that have been reported in New York. Nonetheless, because of the surge planning, we have taken all the precautions with respect to shutting down all routine surgeries and also curtailing our transplant programs significantly. Our total solid organ transplant program has been decreased by about 80%. In terms of heart and lung transplants, we are still doing the highest priority patients for transplant, really transplanting those patients who are on temporary mechanical support in the hospital or multiple inotropes, or who may have MCS but are deemed to be at high risk from home. With respect to the screening for COVID, we have, I would emphasize the importance of screening the donors with multiple testing. At our institution, we're requiring BAL if available and nasopharyngeal swab. But additionally, I would reiterate the importance of looking at the CT of the chest, which has shown to be very helpful in getting a diagnosis. There is also a concern for nosocomial acquisition of the virus for both the donor and the recipient. And we have a case report in the Journal of Heart and Lung Transplantation this week relating to one donor which probably acquired the infection in the hospital. Many of these donors may be in the ICUs for several days here in the United States with plenty of opportunity to acquire the infection. And so we require testing just prior to organ procurement for these donors. We also ask whether the donor is situated in an ICU that may also be housing COVID patients, because that may be an additional risk for donors, and that may also be an additional risk for recipients if they're going into a unit post-transplant in an ICU that may be shared with COVID patients, which is less likely, but there are some staff that are still being shared between units. There was one case in the United States of a liver acquisition that was not diagnosed with COVID-19. 3 organs were subsequently passed on with COVID-19, and more concerningly, a member of the procurement team and a member of the surgical team became infected as well. So it is a real risk having a positive donor. With regard to our surveillance programs for patients who are further out from transplant, we have significantly curtailed our biopsy programs and converted to non-invasive monitoring using AlloMap and cell-free DNA. Fortunately, we have the ability to use mobile phlebotomy and telemedicine, so patients don't have to come to the hospital. They're able to get their blood work done by a phlebotomist who comes to their home. And in terms of angiography, we've been able to utilize the fruits of a recent study that we've done in conjunction with a group in Paris and Belgium that used artificial intelligence to predict patients who are at highest risk of developing allograft vasculopathy. This paper is now in press in circulation and has proposed an online calculator where you can determine the risk for the patient in terms of developing allograft vasculopathy down the line using both donor and recipient risk factors. So we've used that and managed to cut down our angiographic programs by about 80%. And most of our outpatient management is now really done through telemedicine. The only patients we're doing biopsies are on our early transplants within the first month or 6 weeks. And since our lockdown, we have still been doing transplants. And last week we did 2 transplants. So The volume is significantly lower, but it's still there. And I'll stop there. Thank you.
Thank you, Jignesh. So before we leave you, there's one question from Dr. Nanda Kumar here. What are the changes in the immunosuppression you would advise if COVID plus or COVID minus, or would it make a difference in these two categories?
So at our institution, we're not making any changes to immunosuppression immediately post-transplant. Those patients that need cytolytic induction with ATG are still getting that. We are not a standard induction center, so we don't use it on everybody. Our steroid, tacrolimus, and CellCept regimens have not been adjusted for the immediate post-transplant patients. If the transplant patient has become infected, at that point we will decrease or discontinue their CellCept, given the frequency of lymphopenia that's observed with the condition and the overall need to decrease immunosuppression.
Thank you, Dr. Jignesh. Coming point. There are two questions. I think Prakash will ask him. One is from Dr. Nandkishore Kapadia, and another is from Dr. Sandeep. So Dr. Nandkishore is asking whether your routine for the donor, a CT scan, would it be enough as a surrogate for possible COVID? I mean,
no, as I said, I think they should all be tested. The donors should all be tested in terms of their swabs, PCR.
So CT scan, you think, does it have a role?
CT scan, sorry, yes.
CT scan
so, well, most of the lung donors, you can. I think the question mentioned in, I can't bring it up at the moment, but that you can get early ground glass changes even before patients are necessarily symptomatic, and that's been reported in the literature too. So it would be prudent to try and do a CT scan. But of course, in the absence of an actual PCR test for COVID itself, you don't always necessarily know what the cause is for those CT changes.
All right. Now, the other question from Dr. Sandeep: what are the changes you would employ in the theatre for in a COVID situation for CPV or VA ECMO, especially in lung cases?
Oh yes, I typed up that answer. So no changes apart from that dictated by the circumstances of those patients or any particular comorbidity that you need to face. The only other thing you would do is continue the extra vigilance in terms of non-essential contact and hypervigilance of any infection, not just respiratory, but also surgical wounds. But the other thing that is increasing in the literature is the suggestion that there are some cardiac morbidities too. And there have been patients who are not necessarily symptomatic, but have had cardiac arrests with COVID that have been known to be COVID-19 without any history of cardiovascular disease. So, and I don't know whether that's related to increased microvascular plugging. Certainly that's been noted in the lung, and it could be the similar thing in the heart that's causing the rise in troponin that's been also been described in the literature.
What about anticoagulation? Would you maintain same regime or it would change because of the
I think we would maintain the same degree of anticoagulation, just to be extra vigilant that you are getting the appropriate levels in the, for anticoagulation, that you're not leaving the patients too far out, so that the interval between the potential peaks and troughs when they're gone home is not so evident.
Prof. Detalle, do you recommend that if we do an off-pump lung transplant rather than doing it on an ECMO and CPB at this stage would be more beneficial?
Well, I mean, a lot of the programs do, I think, increasingly off-pump lung transplants. If you can, I think that would be sensible. But if you have to do it on pump, it's done because of the complexity of the procedure.
Thank you.
Any more questions, Ravi, Prakash?
I have one question for Dr. Jignesh, as usual. What do you think, sir, is the role of tocilizumab, the new IL-6 inhibitor? I mean, in your practice, I think you mentioned that you have some experience with that for a COVID case.
Yeah, you know, we just, as it happened to be doing a randomized trial of tocilizumab, which is an NIH-funded multi-center study looking at the post-transplant effects, because it's a master regulator of both T cells and B cell activity, and also regulatory T cells. So we've been involved in this randomized trial for some time, but there are some anecdotal data suggesting that the use of tocilizumab, clazakizumab, and sarilumab, which are all forms of IL-6 inhibitors, may be beneficial at curtailing the cytokine storm associated, the phase 3 part of the illness of COVID-19. And certainly anecdotal data appears to be positive. At CEDARS, we've actually used it on 44 patients with COVID-19 who've had significant respiratory compromise. And of those 44, we only had 1 death. Now, it's not a currently, we are participating in a multi-center national randomized study looking at tocilizumab. So we'll have the real data to suggest whether it really works or not. But it does anecdotally seem very promising. We had 1 transplant patient with COVID-19 who actually turned around within 24 hours after receiving clazakizumab. So it certainly appears that it may be something that might be of benefit, particularly for the patients who are at risk of developing the cytokine storm.
Ravi, may I ask one last question to Peter?
Yes.
Peter, is there any way we can identify people in a wait list? Do we have any statistical model to tell they are likely to die in 2 months, 3 months, anything like that? Do we have anything like that?
Not that I'm aware of. I mean, there are various survival prediction models, but I don't think any of them, they're good if you apply them to 100 people, but not to an individual. I think that's the challenge that we face. And I think we all see patients in our intensive care unit who you think aren't going to survive the next week or the next 2 weeks, unless they have some major intervention, be it mechanical support or transplant. But it's difficult. I'm sure there's an artificial intelligence program that can be applied to various parameters to come up with an estimate. But I personally still rely on clinical judgment. And as I was saying in my talk, we do have COVID patients in our ICU who are separated from the cardiothoracic ICU. But we, because there's been this big shutdown in elective surgery, there are ICU beds. So we feel that if there is an opportunity to transplant, we should be going ahead and making use of that resource. The only other thing I might add is that, like Jignesh was saying and Balakrishnan, that there's been we've reduced the number of surveillance biopsies we've been doing in the early post-transplant period. We have a particular interest in cardiac MRI, and we feel that that's a very reliable alternative to biopsy. We don't use AlloMap and we don't have cell-free DNA as alternatives, but imaging with MRI has been, in our hands at least, we're very comfortable with that.
Thank you. I think now the time is overdue. If there are some more questions, the speakers would answer them online. We'll keep the answers on our website. Now, on behalf of INSHLT, I thank the speakers, Professor Peter McDonald, Dr. Allen, and Kumud, and all the panelists who have actively participated, improving our knowledge at this difficult time. Same time, I would also thank all the participants who have been part of this program today webinar. And I thank Hallmark Group, Seshadri, these people who have organized an excellent webinar Zoom program for us. And at the same time, I need to thank one last but not the least person who sponsored this program, the Biocon company, the drug company which makes immunosuppressants. It sponsored our webinar today. Thank you all very much.
Thank you
Thank
for
you,
hosting.
Gopala. Good to see you, Jignesh.
Thank you to
Bye,
everybody.
bye, everyone.
Thank you.
Prof. Peter, one last question. Prof,
Yeah, go ahead.
how many mechanical circulator assist LVADs have you done at St. Vincent's during this time of COVID?
I'm not sure. We've done 2 in the last, or since the start of April. I'm not sure about the number. We've been doing 2 or 3 a month in this year, so I'm not sure of the exact numbers. But we did an LVAD in a critically ill patient on Monday of this week, and we did an 18-year-old girl. She had an LVAD at the start of April as well. So they're the 2 recent ones that spring to mind. But yeah, I mean, we are still, as I say, we still have the ICU bed capacity to do these cases, and we, particularly we're expecting that donor referrals will diminish, and long-term mechanical circulatory support is going to become increasingly important in sort of bridging these patients through this COVID era to be able to get to transplant on the other side.
Thank you, Prof.
Thank you, Prakash, and thank you, Ravi.
Thank you all.
Thank you, sir.
Thank you all.
Bye.
Okay.